So thank you very much for the opportunity to speak here today. My name is Capaccione. I'm presenting on behalf of the Department of Radiology, our work on the pulmonary embolism rate in patients with COVID-19. So here are our disclosures. So as we all know, COVID-19 rates have been on the rise ever since its first zoonotic transfer around the turn of the year, and continue to rise both abroad and here in the United States. And the United States has been hit very hard. Our own New York City has been the epicenter of the pandemic, although now it has begun to really spike in other places around the country. And so early in the pandemic, the Centers for Disease Control put out this informational bulletin where they demonstrated sort of the characteristic presenting symptoms of COVID-19. So as we've heard very much anecdotally, patients present with cough, fever, chills, muscle pain, shortness of breath, and a few other symptoms. But as more and more of these patients presented to our medical center and medical centers throughout the region, we found that there's actually a relatively high rate of thrombotic complications. Clinicians were noticing that patients were presenting with different variants of these complications. People began to study this throughout different disciplines and found that there was high levels of DVT. They studied the actually thrombotic complications in patients who were already anticoagulated, and they studied people who were actually presenting with stroke. So throughout many different medical centers, many different contexts, this became a theme. Here at Columbia, we also started to notice a high incidence of thrombotic complications. So this was a patient who was in our ICU who was positive for COVID-19. Here, this is a Doppler ultrasound of the lower extremity. We're showing the left femoral vein and artery. And on the top of the screen, I'm going to point, you can see that this is the artery, and we see that there's flow within it, but within the vein, we see that there's no flow whatsoever. This is corroborated on the spectral tracing, where we see that there's no spectral tracing whatsoever. So this was an occlusive thrombus of the left femoral vein. In a similar case, this is a patient with COVID-19 who presented initially with claudication and was found to be positive for the virus. And we see in their chest CT that they have a very characteristic pattern. So they have the lower lobe predominant and peripheral predominant ground glass consolidations and opacities. So this is a very nice example of COVID-19 infection. But when we performed a CTA runoff, so this is a study where we're looking at the arteries as down through the body, we actually see that there's some arterial thrombus here, and you can notice it as we trace down the left lower extremity vasculature. We can also see it continuing here in the popliteal artery behind the knee. So this is a patient who had an arterial thrombus in contradistinction to the venous thrombus we saw in the prior study. We also started to notice an increased rate of thrombotic complications in our neuroradiology side. This is a patient who had multiple ischemic infarcts throughout their brain. Here I'm showing just two of the areas. So this was very consistent with the sort of showering of emboli picture where there's multiple infarcts. And we see them here in the periinsular region. And there were many cases of this. And then in the cardiac section, we also saw thrombotic complications. So here we have the heart, which is cut in what we call short axis. And in the inferior aspect of the heart, we see this hyperenhancing region. And this was on delayed hyperenhancement. This is very characteristic of an infarct. When we look at this on the dynamic imaging, so this is a cardiac MR, if we look at the apex of the heart here, we see that it's not moving normally as it would. Let's play this again. And so this is characteristic of the results of having an ischemic infarct, and this is in a patient with COVID-19. And then we also started to notice a number of patients had pulmonary emboli. So this is a patient with COVID-19 infection. We also see the characteristic pattern of peripheral ground glass opacities, lower lobe predominant, and consolidations. And so this is a very characteristic COVID picture within the lungs. But when we look at their arterial phase study, we see that as we scroll down to the pulmonary arteries, and if we follow this is the pulmonary artery, as we follow it down, we can see that there's a thrombus right there. And I'll just stop it and focus on that. So this is a right lower lobe thrombus right here in a patient with COVID-19. Here we have another case of a patient with similar pulmonary findings, peripheral ground glass opacities, with a lower lobe predominant distribution. And when we look at their CTA, we see that similarly they had pulmonary embolus. This is a very serious embolus because you can see that it bridges. This is called a saddle embolus. So it's extending to both the right and left systems. And as we continue down, we see that there's emboli throughout the vasculature, the pulmonary arteries. And so this person had a very heavy clot burden. And if we go back and we look at their heart, we see that the right ventricle is enlarged. There's some straightening of the interventricular septum. And when we scroll to their liver, we actually see that there's some contrast in the liver. So these are all signs of very serious disease because the heart is strained. It's having trouble pushing the blood forward. And so this was a person who was very sick. So based on all of these things, we asked the question, do patients with COVID-19 have an increased rate of pulmonary embolism? So to address this question, under our IRB approved protocol, we queried our system Catalyst to look for studies of CT angiograms for PE that were conducted between 2/28 and 4/8, which was the height of the pandemic, and the pandemic was declared on March 11th. So we found 134 exams were performed that met this criteria. 8 of them did not have complete data, so that left us with 126 exams. For each of these patients, we analyzed the medical record to find the demographics, the lab values. We looked at the imaging to identify the imaging findings, and we also looked at comorbid conditions. What we found on this analysis was that we had 51 patients who were COVID-19 positive who met this criteria and 75 who were not. There was no statistically significant difference in the age of the patients. We did find that there was a slight preponderance of males, and we attributed that to small sample size. In the literature, males tend to do worse who have COVID-19. However, they don't have a higher rate of infection. We noted that the patients who were COVID-19 positive had a statistically significantly lower oxygenation. When we looked at the data in a more granular way, we found that there were actually several cases of patients who had extremely low oxygen saturations on presentation in the 50s or the 60s. So that's extremely low and in a sense pulled down the average for this group. None of those patients were in the COVID-19 negative group. The COVID-19 positive patients also had significantly more consolidation on their chest CT, which is not surprising because that's a characteristic of the infection. And then we found no difference in the rates of diabetes, hypertension, D-dimer, or PE. So very importantly, answering the study question, is there a higher rate of pulmonary embolism in these patients? We found that indeed the answer was no. There was a 20% rate in the COVID positive patients and a 19% rate in the COVID negative patients. So analyzing the patients who were positive for COVID-19 in more detail, looking at the ones with and without PE, we had 9 patients who had PE in this population. We found no statistically significant difference in the p-values. In the age range. We found no significant difference in the gender of the patients, the oxygen saturations, whether or not they had a consolidation, or the comorbid conditions. We did find a statistically significant difference in the D-dimer rates, so 9.9 essentially in the patients with PE, and about 4.0 in the patients with no PE. So this was consistent with prior literature suggesting that, supporting that D-dimer is elevated in patients with PE. And it's important clinically because it allows us, or it suggests to us that if a patient with COVID-19 infection has an elevated D-dimer, then they should go on to be treated like someone who has a high suspicion for pulmonary embolism and should be receive a CTA per PE. So we found it surprising that the patients did not have, the COVID-19 positive patients did not have a higher rate of pulmonary embolism. And so looking at the literature and what other groups have found, initial studies did show that there had sort of questioned whether or not there were a higher rate of thrombosis. So more recent studies have shown that patients have microthrombotic disease, not macrothrombotic disease. So looking at the study, Pathological Evidence of Pulmonary Thrombotic Phenomenon in Severe COVID-19, this is a study that looked at autopsy samples of patients. And here I show a picture of the lungs that was taken from their paper. Here the researchers were able to show that there were actually microthrombi within the pulmonary vasculature. So in terms of what we found in our study, this suggests that while there are no PEs that can be detected on diagnostic radiology studies, there are likely pulmonary microthrombi, which are leading to the poor oxygenation and oxygenation deficiencies in these patients. So to get at this from a radiology perspective, a group at Massachusetts General has looked at the use of a technique called dual energy CT. Dual energy CT uses two energies when the patient is scanned, but importantly, it allows us to differentiate among different materials. And in this case, using iodine and water, they're able to differentiate areas of decreased or increased perfusion. So in their paper, they showed this image where you can see in the region of these characteristic COVID lower lobe predominant ground glass opacities, we see that there's a corresponding defect in the perfusion on the perfusion map. So prior to this at Columbia, we had not been using dual energy CT. However, during the pandemic, we initiated the dual energy CT protocol so that we would be able to look at these patients using dual energy CT. So here I'm showing a positive case of a patient with a PE. And in case you missed it, I will just pause and go back so we can focus on that area. So scrolling through here, starting from the top, we can see that the area of PE is right here. So you can see the occlusion within the vessel. Now, when we look at our dual energy CT, we run it and focus on the area that's the left lower lobe where that PE was. What we can see is that there's a perfusion deficit corresponding to the area distal to the pulmonary embolism. Now, just going to pause it there so it's easier to see. Okay, so you can see that compared to the contralateral side, there's a deficiency in the perfusion distal to the embolus. So far, we haven't been able to scan any of the patients so far of the patients that we've scanned with COVID-19, none of them have actually been positive for pulmonary embolus, but we continue to now scan all of our patients this way. But I did want to show this is a patient who was positive for COVID-19 and has those characteristic ground glass opacities that I've discussed. And then when we look at their dual energy CT, we actually see that they have high signal. So it's suggestive of increased perfusion, which is compatible with infection. So taking all of this together, our study demonstrates that there's no increased rate of pulmonary embolism in this population of patients who are positive for COVID-19. However, our data support that there's most likely thrombotic disease, microthrombotic disease in these patients. And so with the use of dual energy CT, we will most likely be able to see perfusion defects in these patients, and hopefully that will allow us to give increased information to the clinicians so that they can then be treated for their thrombotic disease and with anticoagulation, and hopefully this can
give you your 2-minute mark.
Thank you. Hopefully this can positively impact their management. So with that, I would just like to thank everyone. My mentor, Dr. Salvatore, who did an amazing job leading our efforts for the COVID-19 research in radiology. The RSNA I'm grant funded by, my residency program, my program directors, the division chiefs, and then the entire thoracic radiology section here at Columbia. So with that, I'd like to thank you for your attention and take any questions.
That's great. So let me check with any question. Andy, go ahead.
Yeah, that was a really interesting presentation, and I wonder if you know whether other coronavirus infections have pro-thrombotic presentations as well.
Yes, and this was studied in this, the SARS-1 pandemic back, I think, I don't know what year that was, but several years ago. And I believe that did have an increased rate of thrombotic complications. And then in the MERS virus, in the MERS epidemic, there were no studies looking at a clinical population as we did. However, they did studies in mice where they looked at the pathological sections of mice lungs that had been sacrificed, and they found microthrombosis within their lungs, similar to what we're finding in autopsy samples.
And so do you think this is endothelial cell related as to mechanism?
Yes, so this is probably related to endothelial cells.
Great. Janine Darmiento?
Yes, so you said that recently you're screening all of your patients with dual CT, and you didn't see any evidence of emboli. Do you think that's because of a change in treatment?
I don't think so. So we've been scanning all of the contrast enhanced, so the PE studies with the dual energy protocol, but we've only started within the past 2 weeks doing all of the patients with this. It took a while from a physics perspective to get it completely up and running. So I think that the treatment recommendations have been based on the critical care recommendations that patients who are critically ill receive anticoagulation as part of their sort of critical care. I don't believe that it's any different for those patients than it is for patients who are COVID-19 negative. So I don't know that there's been a change. It's just we haven't had a chance to accrue enough patients to be able to see these patients in their radiology studies.
Yeah, there has been a little bit of a change, and there is a trial now at Columbia. So that's why I was wondering if you correlated any of that.
We haven't had the opportunity to yet, but we would love to in the future.
That's great. And Jahar Bhattacharya?
Oh, thank you. I thought that was a great presentation. Non-COVID ARDS has been known for a long time to be associated with thrombotic phenomena. Many years ago, they tried to start a trial to anticoagulate as a treatment. Nothing worked. But the question I have for you is, I have two actually. One is this dual CT approach looks very interesting. Has this been done for non-COVID ARDS, number one? And did they find thrombotic phenomena? That's question one. And the second one is in the new dual CT studies that are being done at Boston and here, do you see thrombotic phenomena in non-congested areas? So one expects in the region of congestion where there's edema, there's going to be hypoxia, there's going to be vasoconstriction, there'll be, stoppage of flow and thrombotic phenomena. But what about areas where there is no congestion, there's no edema, no consolidation? Do you see thrombotic phenomena there?
So in terms of thrombotic phenomenon, the study from Massachusetts General, that was only demonstrating the perfusion deficiencies in the areas of the consolidations. And in our experience, that's also what we see. And then we obviously see the defects in perfusion distal to emboli in the patients who we've seen with pulmonary emboli, but we haven't seen any perfusion defects in areas that are not affected by either of those phenomena. With regard to your first question regarding whether or not they've studied this in ARDS that does not have pulmonary embolism. So to my knowledge, I think the answer is no. This is a relatively new phenomenon. There was a recent paper, I believe it was an AJR, regarding the different applications of dual energy CT. And with regard to thoracic imaging, really it's this pulmonary emboli and perfusion defects that are most studied with it. They also looked at the ability to differentiate stents within the thorax, like post-TEVAR studies, to sort of subtract them out. But as far as I know, because of its relatively new in terms of the imaging modalities that we have, or the sort of adjuvant things we can do with CT imaging, I don't think it's been widely studied in ARDS or for other applications.